Okay, good evening, everybody. Welcome to this 53rd comprehensive course in echocardiography. We have come a long way from our beginning, and we are going to talk about systole and diastole to revisit, like many questions, many things you must be having in mind. And when we learned from the last two sessions, it was really difficult at one time that many of you did not understand what was going on in systole and diastole. So that's what our aim is. Well, we are from Jurap Institute of Echocardiography, Ultrasound and Vascular Doppler, Delhi. Many accreditations, as you could see over here, right from Guru Gobind Singh IP University, along with the Parul University programs. We can boast of saying that it is the longest residential training program in India in private sector for more than 26 years. The people who have attended this program have risen to Director of Non-Invasive Cardiology in major or tertiary cardiovascular systems, hospitals, and a list of people who have visited our center from around the world. We started this program on 15th of April 2026. We are in July 2026 right now. And I'm Dr. Rakesh Gupta to talk about this particular modality, systole and diastole. And I'll try to show you as many slides as possible of live echo recordings so that you have an idea what's going on in these systole and diastole. Well, Dr. Sanjay Mittal did touch this topic of concept of wall thickening abnormalities. Now look at this slide very carefully once it plays. So we understand that we have pericardium, we have myocardium, and we have endocardiums. So when we look for echo, we are not looking at the myocardium. This is myocardium. We are looking at this endocardium, which shows thickening. Look, this is the endocardium. And this what endocardium is. We look at this endocardial thickening to say normokinesis, hypokinesis, akinesis, or dyskinesis. Now you can see those images, which is septum and lateral wall. And if you look carefully for these images, what you'll see? You will see that they are contracting or they are thickening at the same time. Look, this is thickening of the endocardium, and that's what we look at when we look at abnormalities. Now, same thing we do and look for hypokinesis and akinesis or dyskinesis. When we talk of a wall motion abnormalities, we look at 4-chamber view, we look at 2-chamber view, we look at 3-chamber view to say that whether this segment is normokinetic, hypokinetic, or dyskinetic. Unless until we see this endocardial thickening, we'll not be able to realize what exactly has been going on. So, normal, we have almost more than 50% of a contraction. This is an arbitrary figure. Nobody is able to say this figure till date, how much is really. It is the relatively perception of thickening of endocardium, which we see. So what do we see? We see a reduced endocardial thickening in hypokinesia. There is no thickening in akinesia. The outward bulging is present during every systole, that is dyskinesia, and hyperkinesia is excessive contraction. Now, we have to go and look at these kind of things. Somebody asked last time, what is wall motion score index? Look, every segment, if it's a normally contracting, is given 1 point. So we have 16 segments. 16 into 6 divided by 16, you get a wall motion score of index 1. Suppose your 2 segments are hypokinetic. So what will happen? Out of 16s, 2 segments are hypokinetic. So what will happen? 14 segments are normal and 2 hypokinetic segments will give you a score of 4. 2 plus 2 into 4 plus 14 will give you 18. 18 divided by a 16 seg point will give you a figure of wall motion score index. So 6 segments, for example, is akinetic. That is 18. Akinetic is 3. 10 segments are normal, so score is 10. 18 plus 10 is 28. 28 divided by 16 will give you a score of 1.75. Higher the score, worse is the prognosis. Because if we have a score is 1, that's a beautiful, perfect scoring system. But as the score increases over a period of time, you'll understand the segments either they become akinetic, dyskinetic, or aneurysms. Let's think we have one segment which is akinetic, one segment is aneurysmal, then 3 plus 5, 8, 12, 14 plus 8, 22, 22 divided by 6, 8, 16 would be the wall motion score index. Now look at this segment very carefully. This segment has got everything what you want to see. In this segment, if you look carefully, is this segment is thickening a bit, normokinetic. This is hypokinetic. If compared with this segment, it's not thickening at all. Then another important part is look at this basal and mid septum. It's almost akinetic. This is again hypokinetic. This is again hypokinetic. This is normally contracting and this is hypokinetic. Now see it again. And that's what you need to appreciate. This is for sure. There is no endocardium seen over here. There is no thickening. So mid and basal septum is akinetic. This segment is significantly thickening. We can say mid and apical segments are significantly thickening. In comparison to this segment, this is less thickening. And this segment is almost akinetic. Now see it again. And that's what you need to interpret. Like more than 300 studies are required, a guided one to talk about independent wall thickening abnormalities. Now what do you see? If you look carefully, this apical septum along with apex is hypokinetic. Mid and apical septum is hypokinetic. All right. Now look at this segment. The apical segment with every systolic thickening is bulging out. Look very carefully. All the segments they're contracting, but the apical segment is bulging out with every thickening. All segments they're contracting, but the apex is bulging out. That is dyskinesis. Now, another example. Look, apical septum along with apical lateral wall is almost akinetic, thinned out, and hyperechoic. Mid and basal lateral wall is normally contracting. Basal septum is normally thickening, but mid and apical septum and apical lateral wall along with apex is akinetic. There's hardly any thickening and is virtually thinned out. Any segment which is less than 6 millimeter in size is akinetic, non-viable segments. Now again, example of three-chamber view. What does it say? The mid-anterior septum over here, along with the apex is akinetic, and sometimes it looks apex is again bulging out. This is aneurysm. Look, it's a sac-like structure which is seen both in systole and diastole. Now compare this sac-like structure. Look at this sac-like structure. This is true aneurysm. Compare this true aneurysm with dyskinetic segments. They're not bulged out. They're not persistent dilatation during diastole. Their systolic contraction is present and the segment bulges out during systole towards outside. Now look at this example. This is which view? The lateral wall is over here. This is mid and basal septum, which is thinned out, hyperechoic, and is scarred. See it again. Look, this segment is almost akinetic. This should be a two-chamber view, but this is truly not a two-chamber view because we can see a papillary muscle on the other side. So mid and basal inferior wall or mid and basal septum, whatever it is akinetic. We did discuss about hypokinesis. Now this is what is tardokinesis. What is tardokinesis? You know, what exactly happens when the normal segment or hypokinetic, so not normal, hypokinetic segment is pulled by a normokinetic segment, it sometimes looks like as if the segment is normal. The word is tardokinesis. Then teeth ring effect. The hypercontractile segments pulls the hypokinetic segments and it appears as if it's normal. I'm sorry, my word of tardokinesis was a little wrong. Tardokinesis is delayed contraction, not pulled up segments. It's a delayed contraction of particular segment, which is not seen by naked eye, is a sign of ischemia and can be detected by two-dimensional strains. Look, this is the normally contracting segments, and this is delayed contracting segments by two-dimensional strain. And when we talk of this two-dimensional strain, delayed segment, that is known as tardokinesis. Teeth ring effect is when a hypercontractile segment pulls a hypokinetic segment, and that hypokinetic segment looks like normal. This is known as teeth ring effect. Now, apart from this wall motion abnormalities, we have many segments either because of LBB or RBB or post-surgicals. So many things where you see an ECG. So how do we look for these kind of things is, we look at the contraction pattern and look at this contraction pattern in this three-chamber view. Look, this segment is thickening, but it shows a jerky motion. And that is known as left bundle branch block. And you will be able to realize left bundle branch block when you see the ECG. You'll say the patient has got a LBB pattern. And when you look at an echo pattern of this LBB, this segment is very well contracting. This is mid-anterior septum, which shows a jerky septal motions. Now, many of you can ask me whether this LBB is associated with coronary disease or not, especially the anterior wall MI. The answer is just focus on anterior wall. If anterior wall is contracting well, it means there's no associated MI. If anterior wall is not contracting well, it means we have an MI. Same as RBB. So this is looked as a single jerk with RBB. So nothing significant as far as RBB is concerned, because RBB could be seen in a normal variants also. Then come tissue Doppler imaging. Tissue Doppler imaging tells you how much the segment is thickening over a period of time. That is strain imaging. I'm not going to talk at this your levels. What is TDI and what is strain rate imaging is. This is known as B-scan color. This is just a machine which gives you a different color for whole of the segments, because our eyes are less tuned to grayscale, but they're better these B-scan colors. Then every machine is a harmonic imaging. Look, very important issue which you see in this patient is, we can see this apex over here, but we can't see a good apex over here. So what we use? We used a matrix crystal transducer. And as told earlier, matrix has got a line of a transducer both in horizontal as well as vertical. This is myocardial contrast agent. Size less than 6 micron in size, injected on the right hand side of the arms. It bypasses lungs and comes and opacify the LV cavity. So when we talk of a wall motion abnormalities, we always talk of a systolic function. And this systolic function, I'm not going to go in details of this, is being calculated by biplane modified Simpson's method. And this biplane modified Simpson's method, male more than 52 and female more than 54 millimeters of mercury, 54% of the LV contraction. And we always take into consideration the 16 segment model or 17 segment model, whichever you want. So if you talk of a 4-chamber view, we talk of middle basal septum, middle basal inferior wall supplied by RCA. Middle basal posterior wall, middle basal lateral wall supplied by circumflex. Rest all by LED. And that's what you should remember when we talk of a wall thickening abnormalities. Now the thing is, look at LED supplies a large chunk of an area, almost 50% of the supply of a coronary artery cells. Circumflex 25, RCA 25. And this circumflex, look, it can be a dominated, suppose it is attached to the posterior descending artery. So it goes and supplies the inferior wall also, if LCX is dominant. If RCA is dominant, it goes and supplies the posterolateral wall also. So variation could be many. And at the same time, when we talk of a wall motion abnormalities, when we talk of a 16 segment models, the most important thing you should remember is we have to look at the contraction of RV function, which could be because of a TAPSE, or could be RV free wall TDI, or it could be a strain image. So at your level, if you do by TAPSE, that'll be great enough. And if your patient of inferior wall MI comes, we always have to look for RV free wall TDI, TAPSE. Because that's one condition where we don't use a drugs which reduces the preloads. So this is what revision of wall thickening abnormalities in patients whom we look for a coronary artery disease. Moving on from this, let me go and show you a couple of wall thickening abnormalities in specific territories. Rajiv, go ahead. Rajiv, unmute yourself. You can ask a question right now. What's your roll number, Rajiv?
Sir, 29, sir, 29.
Rajiv, you are not located your roll number correctly, Rajiv.
Yeah, yes, sir, I'm putting it right now. Sorry, sir.
Go ahead, Rajiv.
No,
Your
no
question.
questions, sir, right now.
No question.
No, sir, no question. Yes.
All right. Next is Dr. Rupali Kapale. Dr. Rupali, go ahead.
Sir, good evening, sir.
Evening, Rupali.
Sir, can you please repeat LBBB का वो?
I'll do that, Rupali. Just give me a second.
Thank you.
Just give me a second, Rupali. I have to go back and open the slides again. Ask me, Dr. Rupali, what do you want to ask?
Sir, can you please repeat wall motion abnormality with LBBB?
Look, if you are normally what happens is when we have a left bundle branch block, what exactly happens in system? So this shows a jerky septal motion of the septum. Look, it's thickening, but it's thickening in a different way. So same thing can you see in this particular slide over here. Let me just zoom it for you. Now look carefully this slide of LBB. This is posterior wall, which shows a regular thickening. This is diastolic, this is diastolic, this is systolic, this is systolic. Go up. What exactly happened? You happen to see two beaks of the contraction of LBB. So what will happen? The LV segment will go up first in diastolic, then contract, and then go for diastolic. So if you happen to see the initial systolic contraction, then diastolic, then in late systolic contraction, and then to diastolic. So if you're not really sure, just look at this pattern, do an M-word across the parachute short axis view to look for LBB. Now the question is whether this LBB is attached with anti-oval MI or not. So what do? Look for two-chamber view. This two-chamber view has got anti-oval MI, anti-oval. Suppose somebody has got anti-oval MI with embedded LBB. So what happened? Even this two-chamber view, which is not affected by LBB, will show a normal contraction. If it's acute MI, it will show an abnormal contraction. Are we clear? All right. Roll number 13, Satyam.
Okay, sir. Thank you.
Good evening, sir.
Good evening, Satyam.
Sir, can we use MO to determine the contraction during systole? in place of 2D to 2D mode.
What car do you drive today?
Yes, sir.
Which
Sir,
car do you
Innova.
drive?
Innova.
Would you like to buy a Maruti 800 in the year of 2026?
No, sir, because it find difficult to differentiate between the hypokinesia and kinesia in
When
2D
you
mode.
can't drive a car, better buy a motorcycle car, buy a cycle.
Okay, sir.
What will
Sir,
happen with
for
M? What will
sir
happen
for
with M
cross
mode?
checking, for cross
No,
checking, if it is
I'm coming down to your question, Satyam.
yes, sir. Yes, sir.
So how will you drive your M mode in this segment of two chamber?
Draw a line, segment to segment wise.
So just try to do it tomorrow.
Okay. So actually, I don't have 2D machine right now. Yes, sir.
All right. But my answer would be
Okay,
no.
sir.
It's
Okay, sir.
strictly no, because we have to do a two-dimensional psycho wall thickening in the mind.
Okay. Thank you, sir.
Right. Avinash,
Sir, good evening.
good evening.
Sir, kindly show some more example of dyskinetic versus aneurysm and what are its significant value.
Okay. Look, if you look at this kind of a segment, look, apical septum, apical lateral along with apex, it is virtually shows a ballooned out segments. See it carefully. This segment has got thinned out. This is exclusively part which is seen over here. Look, this part is contracting, this part is contracting. This is known as true aneurysm. What exactly happened? Apical septum, apical lateral has become akinetic, and finally they have started bulging out. And this bulge is present even during diastole, which is known as aneurysm. The classical bullet shape of LV is completely gone. Now look for a dyskinetic segments. Look, the bullet shape is still preserved. The apex is not dilated. And on top of that, with every systolic contraction, it's bulging out. Now, what do you say? This dyskinetic segment means the segment which is dyskinetic, it has got a value in the sense that it does not show any systolic contraction inward, it shows a systolic contraction outwards. On the contrary, if this aneurysm is present, so what is the clinical significance? There are very likelihood chances of having an emboli or thrombus formation in this aneurysm. I don't say it is not present in this kinetic segment, but this is more in aneurysmal segments. So you have to hunt for any thrombus which is seen. Suppose, look at my hands. My hands is like contracts like this. Apex contracts like this. If the apex becomes stationary, so what will happen? A lot of blood will start getting collected at the apex level. Fair chances is we start having a thrombi in this aneurysms. And this is dyskinetic, no blood supply, nothing. This is the aneurysmal which has got no supply at all. So what will happen? It could be source of
Thrombus.
arrhythmias.
Sir, where is more chances of arrhythmia and thrombus in dyskinetic or
Correct.
in aneurysm?
Correct.
Sir, I am asking where is more chances of arrhythmia and thrombus in dyskinetic segment or in aneurysmal segment?
In aneurysmal segments. Chances are there in both of them, but more in aneurysmal segments.
And sir, what is the difference between apical aneurysm and versus Takotsubo?
what is the difference between apical aneurysm and Takotsubo aneurysm is, in case of a Takotsubo apical aneurysm means, like, if you look at those Takotsubo apical aneurysm, the apical bulge is present. But the endocardium is not thinned out completely. Endocardium is still preserved. In true aneurysm, like this post-MI aneurysm, the endocardial thickening would be completely lost. It's thinned out completely. So that's what a difference between Takotsubo versus this aneurysm.
And sir, one last question. Can you show some more example of tethering effect in echo?
What is this? Look, whole of the LV is dilated.
Correct.
And apex is akinetic, and sometimes it looked like apex is bulging out over here. Correct? So it's not aneurysm. It's still possibly apex is dyskinetic. Now, tethering effect is when hypokinetic segment is pulled by a normokinetic segments. Now look at this segment. This segment has got dyskinetic phase. But these muscles are contracting. When these muscles are contracting, the chances of forming aneurysm would be much less as compared to aneurysms.
Thank you.
Give me a second. I'd like to show a tethering effect. Now look at this segment. This is hypercontractile. This is normal contractile. This is hypokinetic. Once you play, it looks like as if this mid segment is contracting well. So this is what hypokinetic segment, because of pulling effect, becomes normokinetic. Correct?
Correct. Sir, how can you recognize? This is the
Recognize it by again visualizing them again and again. If you really ask me, you have to just focus on that particular segment, how this segment is contracting. Now I'm focusing on exclusively this part of a segment. But in clinical segments like tethering effects, they do not play significant role in a clinical practice. All right. Dr. Gautam Devnath, go ahead.
Sir, good evening, sir.
Good evening.
Sir, my question is, sir, sometimes, sir, in obese patient or severe patient, it is very difficult to differentiate between the hypokinetic or akinetic. Sir, in our level, what will be our next step to differentiate it? Or is there any role of saying it's a hypokinetic or akinetic? Sometimes I am finding it's hypokinetic. If I write akinetic, is no changes in the treatment, although, sir, what the next step, sir? What will be our next step?
If this segment is hypokinetic or akinetic, if the akinesis segment has got preserved endocardial thickness, which is more than 6 millimeters in size, it means that possible segment has got a chances of recovering back. And that's why we call, like, I'll show you again, that's the model which I was trying to show you. So if you have hypokinetic segment, it means the segment is still viable. If there's an akinetic segment, it could be viable, it could be non-viable.
Okay.
If you have a preserved endocardial thickness, the fair chances is the segment is viable or it's an acute event. Now look at this segments over here. This is an acute MI of a patient. You see whole of this apex is akinetic, but endocardial thickness is well maintained in this. See it again now carefully. Apex is hypokinetic, but it has got endocardial thickness which is maintained with it. So whenever we see a patient with ECG changes, hypokinetic akinetic segment with preserved endocardial thickness, we always start looking for that. Possibly this is an acute event. If it's a chronic event, what will happen? These segment will start shrinking. What normally happens when we develop a infection, when we develop a wound? Initially, those wounds will look as swollen up and finally
The
become small.
fibrotic. Fibrosis happen and scarred happen.
Correct. So this is what picture of a scarred picture is. Look, this is all scarred picture we have. Now this is a classical example of a scarred picture. Look, this is mid basal inferior wall. Suppose the inferior wall is. This is thinned out. If you measure this segment is less than 6 millimeter in size and is hyperechoic. Look, rest of the segments are normally contracted. The normal thickness is present. Look, this is contracting very well. Let's see this segment. This segment, though hyperechoic, is contracting well. On the contrary, this segment is almost akinetic. So whenever you look in your beginning phase of your life of echocardiography is always look at individual chamber 4, 3, and 2, then focus according to segment wise. And majority of time there will be a clinical correlation of segmental wall motion abnormalities with a coronary artery territory. Correct?
Yes, sir.
So next we go to row number 17 online.
Good evening, sir.
Good evening.
Can you please show me the stepwise approach for calculating ejection fraction by a modified Simpson method?
All right. Abhishek, can you wait for some time?
Yes, sir. Yes, sure, sir.
Okay. Because let me take other questions and I'll show you live how to do it.
Yes, sir.
Dr. Rupali, you have some question again?
Yes, sir. It is about the Takotsubo aneurysm, what sir said about. Sir, is it reversible? It is reversible. So that can be another differentiating point between ischemic aneurysm and Takotsubo aneurysm.
Correct. Second important point which I did not touch was Takotsubo aneurysm will not correspond to any single territories. So what will happen? You will find four-chamber view, mid and apical, septum, mid and apical lateral wall. So mid septum is supplied by RCA, apical septum is supplied by LAD. Apical lateral wall is supplied by LAD, mid lateral wall is supplied by circumflex. Now rotate. Mid and apical inferior wall, anterior wall, mid and apical inferior wall. So they do not correspond to coronary disease territories.
Yes, so
that's how it difference.
It will not follow the pattern.
Correct. Second important thing is if you have a Takotsubo, there's a history of a stress.
Stress.
Here's the history of MI. And like I'm sorry to say this, but the most important stress factor in female is loss of love.
Yes.
So that stress factor has produced this kind of a phenomenon. Our classical chest pain, ECG changes and everything is there. You look at a catecholamine levels would be very high over there. And if you look at a cornea, if you look at this, if you want to really go details, we always do an angiogram, normal coronaries, high and catecholamines levels. Treatment management is like heart failure or acute coronary syndromes. And you repeat after 3 to 4 days, we find these people have got started coming back to a normal time. I have got an example. I'm not trying to show you. And my example was hysterectomy-induced Takotsubo cardiomyopathy. The lady got so disturbed when she went for hysterectomy. When she came back, she was in Takotsubo cardiomyopathy. Correct?
Yes, sir.
All right. Roll number online one, Rachel. Good questions, because that I really feel good that I've taken this topic again. Rachel, Monica, Paul, Raghavan. Rachel, go ahead.
Good evening, sir. Good
Good.
evening.
Rachel, question पूछो आप तो.
Sir, it's a follow-up question on Takatsubo. We see patients with generalized hypokinesia among
Rachel, I'm not able to understand your voice at all. Come
one
closer to mic, please.
Yes, sir.
Good, very good now.
Now you can hear, sir.
More than enough.
Yes, sir. Sometimes it's generalized hypokinesia, like you were saying, stress-induced, sepsis-induced, or severe anemia in post-op patients.
No.
How to
No,
differentiate?
don't confuse now.
Yes, sir.
What we were talking of aneurysm, that is bulge, apical aneurysm, or reversal segments. Apex remains contracting, the basal segments become akinetic.
Okay.
So that is stress-induced issues.
Okay.
Second is coronary artery disease induced when we have an apical aneurysm belonging to LED territory. Third question is, what you ask is toxic myocarditis, global LV systolic function become gone.
Okay.
That is, you will not find to any territory localized, it will be generalized.
Okay, sir.
Then you have
Generalized.
myocarditis. It's like patchy myocarditis when some segments are contracting, some segments are not contracting. All these things will have definite clinical history.
Okay.
Acute MI, stress-induced, and while have a patchy myocarditis, some viral infection, some toxemia,
Okay, sir.
right?
Yes, sir. Sure.
Something
Understood.
like you can't have a typhoid without having a pain abdomen and loose motions.
Yes, sir.
Correct?
Understood.
So it is very, very important every time when you look for this.
Okay, sir.
Avinash, again, go ahead.
Sir, what are the other parameters except echo, parameters or investigations or factors that can help differentiating Takotsubo cardiomyopathy from ischemic cardiomyopathy? Other parameters or investigating factors?
Very simple, like history of stress, catecholamine levels, coronary artery disease not contributing to anything. Normal coronaries.
Sir, angiography, it will be later, but before doing angiography.
We always do an angiogram to make us sure about our diagnosis. Today is not the era of like non-intervention era. Now I can tell you, like I can tell you, look, this is an Takotsubo cardiomyopathy. But how can we be 100% sure about Takotsubo cardiomyopathy? I want to make you confuse more. It could be a myocardial infarction without normal coronary arteries, Minoca and Inocas. You will find raised enzymes, raised everything. Look at the coronary arteries, they are normal. And look at the territory of a coronary artery disease, LED. But it goes with the symptomatology, it goes with the enzyme levels, it goes with the troponin. Severe chest pain, ST elevation, wall motion abnormalities, but normal coronaries. So the take-home message is, whenever you see something, please correlate with the findings. Don't just jump. Look, this is Takotsubo. This is acute MI. This is myocarditis. Suppose somebody has got a viral fever. He develops a chest pain, breathlessness. You look at a wall motion or a global LV hypokinesia. Do you say that this patient has got a dilated cardiomyopathy? No. It's a myocarditis. And the most important thing, if it's a myocarditis, it will not live in the right ventricular side also. It will involve the right ventricular also. Because it's a generalized process. So, when we talk of a wall motion abnormalities, segmental specific coronary disease. Apical aneurysms, related to coronary disease or Takotsubo. Or you can have reverse Takotsubo with the apex is preserved, the basal segments become ballooned out. History. So all these things, they go hand in hand with history involved. Dr. Surbi, online 8.
Good evening, sir. Sir, I want to ask about how to calculate the wall motion score index in
Okay,
patient with regional wall motion abnormality.
let's do it right now for you.
Thank
Again, did you join a little late? It looks like.
you. Yes, sir. 10 minutes, 10,
Yes,
15 minutes.
I can pick you up, Surbi.
Yes.
We know like who has joined late. You belong to Kangra, and Kangra is like everybody starts sleeping at 8 o'clock.
Yes, sir.
All right. So here's the answer. So wall motion score index is calculated by dividing the number of aforementioned segmental values by number of myocardial segments. If every segment is normal, the score is 1 into 16, then 16 divided by 16 would be 1. Suppose my 6 segments are akinetic. 6 into 3, 18. What is left behind is 10. 18
10.
plus 10, 28. 28 divided by 16, there'll be a wall motion score index.
Okay, sir. Thank you.
Correct?
Okay.
Not a big thing. Higher the score, worse is the problems.
Okay, sir.
All right. So now let me show you. I'm going to stop this presentation over here and switch over to a different presentation.
Good evening, sir.
Go ahead.
Roll,
Go ahead.
roll number 3, sir. Sir, I want to ask in dyskinesia, akinesia, and hypokinesia, we will look for the contractility and motion of the segment or thickness of myocardium or endocardium, sir.
Only thickness of endocardium.
Okay, sir. Okay, sir.
Myocardium would be stationary. Myocardium never thickens. It's the endocardium which thickens.
Endocardium. Okay. So, sir, we look both endocardium thickness and contractility and motion of the segment.
Not motion, we call endocardial thickness. So
Okay, sir.
once the endocardial thickness is normal, thickening is normal, we call it normokinetic. When it's reduced, we say hypokinetic. Which does not thicken at all, we say akinetic. When it bulges out, it's dyskinetic. Persistent bulge during diastolic and systolic is aneurysm.
Okay, sir. Thank you, sir. Okay, sir.
Dr. Rupali, again, go ahead.
Sir, can I ask one more question, sir?
Any number of questions, no problem, Rupali. Number of times.
Sir, what happens to that paradoxical septal motion, which is there in LBBB in case of wall motion abnormality, when it is associated with wall motion abnormality?
When it's associated with wall motion abnormality, it means we have a coronary disease.
Yes. So
obviously, if I see a coronary disease, acute LBB with involvement of anterior wall, I'm going to look for a angiograms, mechanical. Look, now we are seeing many people presenting with LBB, especially the diabetic, obese people. When we look at the wall motion abnormalities, they do not have any wall motion abnormalities, even in anterior walls. So what these people are suffering from? They're suffering from microvascular disease now. If you do an angiogram is normal, like no significant, like significant means no, more than 70% lesion is not there.
Okay. Okay, sir. Thank you.
In your practice, what is the difference would be whether to treat these patients with a coronary disease or not. That'll be the right approach. If you see a wall motion only, they should be treated like a coronary disease.
Yes, sir. Many of times it's a challenge.
It's a challenge. So once you see anterior segment is not represented anyway by LBB.
Yes. Okay, sir. Thank you.
All right.
Good evening, sir.
Good evening.
Sir, roll number 27.
Okay.
Sir, if
Ushan Mishra.
yes, sir. Sir, if jerky IVS is present, then what we interpret? Sir, RBB, LBB.
You
क्या
look
है,
at
sir?
an ECG first.
Okay, sir.
Look, if I have to tell you in a layman's language, RBB will show one jerk.
Okay.
LBB will show two jerks. RBB could be a normal phenomenon. Is
Yes, sir.
seen in large number, exact percentage I cannot tell you right now. But LBB is now, earlier it was considered as LBBs. Any patient who's coming with LBB was, like we always said, that this patient has got a coronary disease. Now we are seeing LBB without even coronary disease. So question is, how do I treat these people? That is an important issue.
Yes, sir. Yes, sir.
So if you happen to see a wall motion abnormalities, always think of a coronary disease. If you don't see a wall motion abnormalities and recent development of MI, then think of a microvascular disease. But again, you should not deny a patient getting an angiogram done.
Okay, sir.
Look, it's all convincing power how to say that this patient has got a coronary disease or not. So once you're sure that this patient has got a wall thickening abnormalities, you should always look for a coronary angiograms.
Okay, sir.
So give me a second. This pack is opening up. The more you do an echocardiography, you will learn more. That is the most important take-home messages.
Sir, I have a question, sir. Can I ask, sir? Gautam, sir.
Gautam, go ahead. Why not? You have all the rights to ask me question, man.
So actually, what I'm saying, sir, sometimes we get a wall motion and abnormalities, a hypokinesia, a lot of hypokinesia, but the ejection fraction is maintained. In that case, patients, should we send them immediately for angiogram or we can take some time? Being a clinician.
Say it again.
Because, sir, a patient with ECG changes, we go through the echo and we find some hypokinesia in the wall. But ejection fraction is good, patient. Ejection fraction maintaining.
It depends on the urgency, you know. Suppose the patient has got a chest pain. Why do you want to deny him from a chest pain? And if suppose the patient has got a stable coronary angina, treat them medically. Who can say no to you?
But I'm saying, sir, ejection fraction has a role, sir. We can send few days after or immediately, sir.
Ejection fraction is a wall motion abnormalities and the at the time of presentation, acute versus chronic.
Okay, sir. In case of chronic patients, sir, if patient is having angina, exertional dyspnea, we find there's some hypokinesia, but the ejection fraction is normal, is maintaining.
Ejection fraction does not play any role. You could have a significant wall motion abnormality, significant coronary disease, maybe ejection fraction is normal. Why? Because if the person is well trained to his physical exercise, so good collaterals will give him a good amount of supplies. So what will happen to wall motion? They may not be there. But the same patient, if he walks for a certain distance, get dyspneic and develop a chest pain, it means there's some artery, despite good collaterals, is showing abnormalities. Start with anti-anginals, start with medical treatment, start with whatever the guidelines are for management of coronary disease. I always say that we should subject them for a coronary disease. Many people, they disagree with us, especially after ischemia trials and many trials. But if you have a lesion in a proximal territory, suppose I've got a lesion in mid and distal LED versus I've got a lesion in proximal LED lesions. He's very well optimized with medical treatment. So if I happen to see a proximal LED lesion, I'm not going to leave that patient, because if he develops a chest pain in a proximal lesion, if the artery gets blocked, it's going to supply a large chunk of a territory. If the same patient has got distal LED lesion, how does it make a difference, man? And some people, they do very well on anti-anginal and guideline-directed medical therapy for coronary disease. So it's a controversial topic. Depends on whom hand you land up. You land up on a clinical person, he'll say medical therapy. You land up with an intervention guy, he'll say angioplasties. You land up with a surgeon, he'll say bypass.
Yes.
So it's all your luck.
Yes.
But guideline says if you have a stable coronary disease, you need not touch this patient, continue with the medical therapy. And how do I perceive in my life is, suppose somebody has got a coronary disease. I optimize his medical therapy. Initially, stress echo was abnormal. I did a stress echo again after 3 to 4 months. That's normal. It means my drug therapy is fully optimized. On the contrary, if I've got a coronary disease, I prescribe with the medicine, but the patient is still symptomatic. So what do you do? Ask the insurance.
Yes.
So it varies from person to person. What kind of abnormality this is?
Yes.
I did a stress echo today.
Yes.
Patient developed a chest pain, very borderline wall motion abnormalities. But looked at an ECG, you know what was the ECG changes? ST elevation in AVR. ST elevation in AVR means left main disease.
Yeah, already absolutely.
So whether his symptomatology is small, large, or medium, whether he's got a significant wall motion abnormalities or not, whether he's got a significant STT wave changes or not, but billing my words, I'm not going to leave him without an angiograms.
That's good.
And in last 40 years of my career in echocardiography, believe my words, what I've learned is none of the finding is specific except the complaint of a patient. If patient category tells you, I develop a heaviness chest on walking, which settle down with rest, it means it is a coronary artery disease. Unfortunately, we have stopped spending time with the subject. We see 200 cases every day. Believe my words, I can't do a justice with 200 cases at all.
Not possible.
I'm not a very large volume center we do in our echo lab. If I do 30 cases on a particular day, believe my words, I'm drop dead by evening. What I'll do is, at 5 o'clock, I'll take out all normal reports, whatever I could do easily. Rest report, I'll leave them over there. I'm there early morning to complete those reports. But every echo has to be perfect echo. We'll ask him why he has come. What is the history? What is diabetic, hypertension? ECG, X-ray chest. What medical therapy is taking? We have an ECG gating. We put in height, weight, body surface area. And then we start recording a complete echocardiogram. We write a provisional report, then we write a final typing gets done, then we recheck it before issuing a report. And if I develop, somebody see a wall motion abnormality, acute chest pain, quickly we'll leave everything aside. That's a priority for us to record and inform the concerned specialist. Concerned person is a referral. If you are doing by yourself, come tell patient's attendant, look, we need hospitalizations. And it has happened many times. Patient has been referred for stress echocardiography. We saw wall motion abnormality. He had a chest pain about 24 hours back. We did a tropi. We have immediately getting a tropi done, quantitative. And if a tropi is positive, no stress echo, patient is immediately going to cath lab. It means if ECG changes are not ST elevations, obviously if not ST elevation, we cannot thrombolize it. It's non-ST elevation MI. The treatment is entirely different. You give anti-anginal, you give heparins, and shift to cath lab if the facilities are there. Or you manage otherwise. So you have to customize patient to patient for a management and diagnosis. And you have to react like somebody who's like a normal echocardiogram, no history of chest pain. If you tell me, I'll tell you, Dr. Gautam, if you sit down with the patient for 5 minutes, do it for next 1 month. Make high probability, low probability, intermediate probability. If you say that, I sat down with the patient, you took an history, he developed मीठा मीठा दर्द होता है, चुभन होती है, डकार आती है. That's not cardiac, man. Very low probability of getting an idea done.
Yes.
If a patient says, I'm normal when I'm sitting down, when I goes for a walk, the chest heaviness comes up. I get breathless. I need to stop down. Then I take some rest, I'm normal. Then I again start walking, again the thing comes back. Your resting echo could be normal, your resting ECG could be normal, but your stress would be abnormal. So what we emphasize in these people, let's do a stress. Symptom-related stress. So that's how we individualize person to person for everything in our life.
Thank you, sir. Thank you, sir.
Rupali, I'll come back. Give me a few minutes time, right? Let me show wall motion normal, how to calculate ejection fraction. Somebody asked me long back. So I'm trying to look for pictures for. All right. Anybody would like to watch for wall motions? Raise your hands. Who wants to get killed? फोकस करो. अच्छा, और अच्छी इमेजेस ढूंढते हैं. हाँ, good. Look, this part is akinetic. Mid septum, basal septum contracting. This apex apical septum along with apex akinetic. This segment is still contracting, but like it's too early for all of you. Let me go to some other picture.
Apex is hypokinetic or akinetic?
Akinetic. We can't see a thickening. When you look for a wall motion voltage, you need to look for Arjun ki aankh. Just look at that segment, nowhere else.
Sir, if you could show some more images or clips of normal endomyocardial motion.
Okay,
Motion.
I'm coming down there. I'm doing that only. Whatever you say, I'll do that.
Thank you, sir.
Now see a normal images. So I'm going to calculate ejection fraction in the subject. So I'll ask this machine to stop. Now scroll at end diastolic or beginning of systolic. So I'm going to look at this cursor, red color cursor, it will go towards over here. So I'm going back. So this is maximum LV size, but unfortunately this is not the correct picture. Let me go somewhere else again. All right. So I'm going to stop this. Take this cursor back. And I've got maximum LV sizes. So this is maximum LV size when the mitral valve is closed and we are in end diastole. So I'm going to measure this. I'm going to go to volumes. I'm going to go to biplane ejection fraction, and this is 4-chamber. So I'll start with this annulus over here, medial annulus, hinge point of AML with N. So I'll just start tracing black and white interface. Look, I'm tracing the black and white interface. Leave it at this. Now adjust my LV apex. My end diastolic volume is 120 ml. So I say, let me save this image for you. So remember 120 ml. So I'm going to 2-chamber. Again, stop. Frame by frame. Beginning of systole. Now look, mitral valve is opened up. So we have to close this mitral valve. Then go for measurements again. Now 2-chamber. So better visualization of endocardium will give you the correct answer. Correct? We forgot a wrong thing out here. So let's move on further. We'll go back to again. Now I'm going to end systole. End of a T wave. So I'm going to measure again. Now my segment has moved from there to this particular point. So this is ejection fraction is 53% in 2-chamber. Suppose that is 57%. So average ejection fraction would be 55%. So idea is start with one annulus, trace a black and white interface, go to apex, come back along lateral anterior wall in this subject to lateral annulus, and the line will join automatically. Take this up cursor, that is length, to give you an area length method in 2-chamber views. And individual segment, look, these are diskettes. So it's calculating volume of individual diskettes and adding them up. That's how we look for biplane ejection. All right. Let me show you some more examples. Dr. Akash Parab. You want to
Yes,
ask
sir.
something, Akash? Go ahead.
No, sir. That is what I wanted to ask about normal endomyocardial thickening clips. So
Okay,
that would
I'll show
differentiate
you
from
more. Just give me
Yes,
show
sir.
more.
Sure, sure. Thank you, sir.
Can you see the slides?
Yes, sir.
Now tell me what is abnormal, Akash.
Sir, apical, there is, the apex, there is slight ballooning.
Whenever we talk of wall motionality, we say basal septum, mid septum, apical septum.
Okay, sure.
Basal lateral wall, mid lateral wall, apical lateral wall.
Okay. So, sir, basal septum is akinetic. Mid septum is akinetic. Apical wall is
There is no apical wall. Apical septum.
septum. Sorry, sir. Apical septum. So it shows a little ballooning out at the apex. A little, yeah. And the lateral wall, yes, basal lateral wall is hypokinetic.
Now concentrate.
Yes,
You
sir.
are concentrating on this myocardium. I'm concentrating on this endocardium.
Right. Okay.
So this is thickening. All of this endocardium is thickening, except
Okay.
for some speckle of endocardium, which is not seen in basal septum.
Okay.
Rest, look at this mid thickening,
Yes.
apical thickening.
Okay.
Apex is thickening.
Okay.
Then Apical anterior wall is thickening. There could be some hypokinesis in the lateral wall.
Yeah.
Correct. Now go to two-chamber view. Whole of the anterior wall is thickening.
Right.
So some hypokinesis on this basal inferior wall.
Right.
Could be. I'm not really sure whether it's there or not. And the crux of the segment comes out. Look, this is akinetic. There's no endocardium seen over here.
Okay. Yeah.
So mid posterior wall is almost akinetic. The endocardium has disappeared. Look, this is contracting and mid anterior septum is contracting.
Yeah.
But once this comes to posterior wall, this is not thickening. There's hardly any endocardium out here.
Yes.
So
Okay.
if you look at, I have to match it as mid posterior wall, basal is still thickening.
Yes.
And mid posterior wall along with mid and basal lateral wall. So what is the territory?
Circumflex.
Circumflex territory.
Yeah.
So what ECG changes would be there in circumflex territory?
Sir, one AVL, there will be changes, and lateral leads, there will be changes. Sir.
So we can have a changes in one AVL V4,
AVL,
5, 6.
V5, V6. Yes.
So akinetic mid and basal posterior wall. That was the answer for this.
Oh, okay. Okay, sir.
And now see in short axis. Look very carefully. All these segments are coming in. This is infraposterior territory.
Okay.
See it again. Look,
Yeah.
there's no endocardium which is seen over here.
Right.
So this is how we look for various things in clinical practice. Let me
Okay.
show you one more example. Now see what is the ECG findings are.
Poor ROA progression, sir.
Poor progression of R wave.
Yes, sir.
Correct? Anything else?
Low voltage.
Pardon, say it again.
And
Low
QS pattern,
voltage.
sir. V1 is QS pattern, sir.
There's no QS pattern. Suppose small
ST elevation V1 to V3.
there's some amount of elevation in V1, V2, V3, V4. 5, 6. 6 is almost normal. 5 is plus minus.
Septum also.
Now look at
septum,
the
yes.
finding.
Septum, yes, sir. Septum is good, sir. Yes. Akinetic septum.
Whole of the septum is akinetic.
Yes.
Mid and basal septum is akinetic hyperechoic. Inferior wall is fine. Basal anterior wall is fine. This is almost akinetic. Severe MR. This is pulmonic flow truncation. Like when we talk of severe MR, so what happens? This jet is going into pulmonic veins. So normal systolic flow velocity of pulmonic vein is more than diastolic flow velocity. Here systolic truncation has happened. S wave has become smaller than D wave. Next important thing in this patient is what we said. Mid and basal septum, correct?
Yeah.
Then apical segments. Then those looks to be more of an LAD territory. LAD with RCA. And why this possibility is said that if there's a dominant RCA, circumflex, which can go and supply to septum also. Not at your level, to say very honestly. Now look at these cases. Let me just zoom out for you because they're too small in size. I can do that. We'll look at first one. All right. So what's the territory involved?
So LED septum, LED is involved, sir. Septum is involved.
I'm not saying LED. I'm saying apical septum.
Ah, yes, sir. Apical septum.
Along with apex appears to be hypocontractile, correct? So when we talk of, we are not going to talk of LED territory. We are going to talk apical septum, apical lateral along with the apex. Now look at three-chamber view. This is mid-anterior septum is hypokinetic. Then we look at two-chamber view. Now it play full screen. Now look at the apex. It looks apex is bulging out. Now look at carefully. This is a patient of acute MI. ST elevation MI was there, and we were able to record quickly because once we have an acute MI, we are not going to wait time. Top eye positive acute MI, quickly shift because minutes matter. So you could have images which are not very good.
Sir, not able to differentiate, sir. Please, can you show us again?
Sure, again.
Yeah.
Can you see this apical anterior wall and apical inferior wall? Now concentrate on apical inferior anterior walls. Focus on these segments. Focus on this segment. They're almost hypokinetic to akinetic. Now mid-anterior septum is also hypokinetic. Look at the endocardium, well seen despite hypokinesis. Let's go to some more examples. What is the wall motion now? Basal lateral wall.
Lateral.
Correct?
Yes, sir. Hypotension.
Two-chamber view, wall motions. So this is the ECG of this patient. You could see this ECG has got ST depression in lead 2, nothing in 3, some in AVF. There's V5, V6. So what do we suspect? Infralateral wall ischemia. If it's infralateral ischemia, either it could be RCA dominant or circumflex dominant.
Yes.
So what we see in this patient was basal lateral walls hypokinetic. Correct? In this, inferior wall is basal inferior wall is hypokinetic.
Okay.
And then look, the crux answer lies mid basal posterior wall is hypokinetic.
Circumflex.
So possibly we're dealing with circumflex.
Circumflex.
And in this patient, I'm not showing you that this patient is. If you do a color Doppler, you'll find significant mitral regurgitation because the tenting effect is lost of a papillary vessels. So I'll stop over here in this segment. Let's see what we have more in our momentary. So I've recorded some images for you in last week. Same thing for wall motion abnormalities. Let me just open them up. not good for your visualization. Let's stop it over here. Let's see what is the wall motion abnormality in this. I can increase the gains now here. Raise your hand if you can identify the wall motions. All right. Now you can identify. So the mid and basal posterior wall. And here was mid and basal lateral wall, which was hypokinetic. Again, not a very good images, but you can see this segment is almost ballooned out segment. Basal posterior wall. Now you can see this very well contracting. This is hypokinetic, this is akinetic segments. Now look at this patient. This patient endocardium is very well visualized. Look, apical septum, apical lateral along with apex, they're almost akinetic with good endocardial thickening. Look at this segment, endocardium is still visualized. So this is the patient of acute MI, ST elevation MI with preserved endocardial thickness. This is akinetic apex. There's no doubt about it. Look, till this point, it's contracting. This point is contracting. This apical septum, apical lateral wall along with apex is akinetic. And there's an organized thrombus in this way here. Look, there's a thrombus out here.
Sir, in this example, is the mid septum contracting well?
This one?
Yes, sir.
It appears to be contracting. Thickening is happening. But you can't see the endocardium out here.
Right.
Why we can't see endocardium? Because this is oblique imaging there. Look at the endocardium which is seen on lateral wall is too much in comparison to inferior wall.
Okay.
When you see excessive endocardium, it means it's compromised at the level of other segments.
Okay. That's why it's not showing.
This is not seen.
Yes. Okay.
This is all what you're asking on that day was like this is what is important thing is. When you'll come for hands-on, then you'll rise. Like acquisition of images is the most important thing. These are the best possible images which are driven from E95 machine. The machine cost is exorbitant. Now, can you see this? So this is acute anti-oval MI. This all segment is, this is a soft plaque, which is thrombus, which is formed. In between, you can see this hyperechoic shadow. Then this is another, this is accessory band with which this thrombus is hanging on from this particular margin. Now you can see this very clearly. So this is attached to this anti-oval, is pedunculated thrombus. So I can see this in 3 dimensions. Now you can see this, like this is LV apex. This is all LV apexes. This thrombus, which looks to be coming from this accessory band, is not so. This is coming from the apical septum and apex. You can see this pedunculated over here. And we can't leave this thrombus like this. Very high chances of developing an embolisms. Now you can see this pedunculated thrombus. And it has all formed because of akinetic apex. Look here, it looks as if it's coming from this accessory band. It's not true. It's coming from apical thrombus only extension. So whenever the apex gets involved, the fair chances is you have to hunt for thrombus. This is apical akinesis. Now this is apex is dyskinetic over here. Otherwise, whole of this segment is akinetic. Like this is a cutoff line. Above that is hypokinetic to akinetic. Hypokinetic, this is contracting very well. All right, questions? Rachel, go ahead, Rachel. Oh, Rachel want to join. She has quitted out. Okay. So any question from anybody? No. So let me switch over now a little bit on diastology. Yeah. This patient was recorded a few days back only. Now tell me the wall motion normality of this patient. So tell me what is the wall motions?
Sir, akinetic, sir. Mid
Global
basal.
akinesis. Ejection fraction when we measured was 22%.
Yes, sir.
Correct?
Yes, sir.
We went on to a diastology in this patient. So this is E wave, this is A wave, the ratio is 2.48. So what kind of a diastolic function she is carrying?
So So we need E prime. Last 3 weeks, sir told E prime is the next thing, sir.
Okay, you need E prime. So E wave is 71. This is septal annulus. This is E prime. Let me measure you. That is 71, and this is E prime septal is 4. 71 divided by 4. 14. E to E prime ratio is 14. We forgot the algorithm completely.
It should be grade 2 at least. Grade 2 diastolic dysfunction.
Sir,
at
can
least.
we get the TR velocity also?
TR velocity,
Sorry,
sir.
grade 3 it should be.
Grade
Since
3, sir.
SI is more
Grade,
than
grade,
equal to 2.
it's grade 3, sir.
Yeah.
EA is more than 2.
In reduced LV systolic function, if EA ratio is more than 2, is always a grade 3 diastolic dysfunction.
Yes.
Yes, yes, sir.
We don't need other parameters. So, do you have, like, I'll just jot it down for you one by one. So, first parameter we saw was EA ratio. E wave was 71, A is 28, EA ratio is 2.48. Correct?
Sir.
So now we want E prime septal and E prime laterals. Septal E prime is 4. So this is what I'm going to measure. This is measuring system. So this is 4 septal E prime. Everybody will agree?
Yes, sir. 71 divided by 4, at least 17.8, sir.
71
divided by 4.
17.8. So more than 10.
Yes, sir. Yes, sir.
So then we look at a lateral annulus. So I went on to measure the lateral annulus now. My lateral annulus is again 4. Correct?
Yes, sir.
No, I'm just telling you how to calculate it, right?
Okay, sir.
So I'm not going to go like next is somebody asked me LA volumes. So where's my LA volumes? I did not do my LA volumes. So I can do LA volumes now. What's the problem? So I'm going to ask this system to stop. This should be an end systole. So I'm moving by frame to end system. Correct? Now look at this cursor. This cursor has gone to end of a T wave. So now I'm going to measure it. I'm going to measure my LA volumes. So I'll go to volumes. I'll go to LA volumes. Unfortunately, this does not have any LA volumes. So what I'm going to do is, FI LA volumes. So let me tell you, like, this LA volume is more than 34 cc per meter body surface area. This is more than 34 cc per meter body surface, is large. Then I've calculated LA strain also in this patient. My LA reservoir strain is +5. So it could be one of them. And then TR jet velocity was 3.25. Correct? So I'll have taken my all parameters. I'm going to get out of this, stop sharing, then go to my diastolic parameters. So I'll have to hunt for my diastolic. All of you have got this book till now. You can't say no that you don't have a book. for systole and diastole. Yeah, this is my algorithm now. So what is my, look at this one by one parameters. My E prime velocity septal less than 6, it was 4. Lateral less than 7, it was 4. Average is less than 6.5. So average E prime velocity is only 4. Correct? Now E2 prime septal is more than 15, it was 17. Lateral is also more than 13, that's 17. Average is more than 70. TRZ velocity is more than
Sir, I
2.3.
cannot see the presentation.
Okay.
Just
Wait a minute. I'm sorry about it. Must speak out, man. This is the right time to speak out everything. Let me share the presentation with you. Like, can you see the presentation now?
Yes, sir.
yes, sir, it's visible.
Computer be tired, oh yeah. Is asking for food. Yeah. All right. So go back. So what was my E prime septal? It was 4.
4 centimeters.
4 centimeters. So it's less than 6. What was my E prime lateral?
4.
Again 4, less than 6. Average, both of them were 4. So average would be less than 6.5. Average would be 4. So first parameter is positive. Now my E2 prime septal, that was 71 divided by 4, almost 17 or 18.
17.1.
Then lateral, also more than 17 or 18 because 71 and lateral E prime is 4. So again 17 and 18. So both of these parameters of more than 15, more than 13 are more than 17. Average is more than 14. Since septal is 17, lateral is 17, so average is automatically 17. So second parameter is positive. Increased CRZ velocity, this is 3.5. So definitely is more than 2.8. So all these three parameter, above parameter is positive. We have a raised LA pressures. Now, if my EA ratio is less than 2, that is my EA ratio more than 2. So I'm classifying as grade 3 diastolic dysfunction with markedly elevated LA pressures. Are we clear? Are we clear or not?
Yes, sir.
So this is how we like to look at it. Now, once we look at these parameters, now all normal LA pressures, reduce E prime only out of these two, one is reduced, then look for EA ratio. My EA ratio is 2.48, does not classify. If it's less than 0.8, more than 0.8, grade 1. And then TR jet velocity alone or increase E2 prime or any two of the above abnormal variables, any two of these abnormal variables. Then you look LA volume index or LA strains. If it's increased, then increase LA pressures. Now let's go back to that lady again. Shall I stop over here? I'll have to just wait for a minute. All right. That lady was Sultana. Now you see a systolic function, you see a diastolic function, and I'll try to show you now IVC. Can you see the slides?
Yes, sir.
Yes, sir.
So we could see this IVC, which is dilated, not collapsing at all. So what is my RA pressure?
More than 50, sir.
More than 15 millimeters of mercury. You see some amount of pericardial effusion over here. So if we have a systolic dysfunction, we have a diastolic dysfunction, we have got a raised pulmonary artery pressure, we have got raised IVC, dilated IVC. So, and look at our heart rate. Heart rate is almost 120, 130. Heart rate would be here. No. Heart rate is not seen, unfortunately. But heart rate was almost 130, 120. So, in this kind of a patient, what would be the first drug of choice? Diuretics.
Diuretics.
So that we are able to reduce
Reduce the
this
preload.
preload or volumetric state. So I have to make this IVC as normal, so that my RA pressure becomes normal. Then same diuretics will help you in reducing my LA pressures also. Because it's also reducing a preload over here. So we are also reducing a preload on the other side also. So my LA pressures are very high. As you can see, we are grade 3 with raised LA volume index. Raised LA pressure. So I'm going to use first diuretics, this ACE inhibitors, then beta blockers, if my BP is normal, and then obviously I'll try to settle this patient by using aspirin, clopidogrel aspirin, along with statins. Then if I suspect ischemic heart disease, obviously I'll be using nitrocontin. If it's not, then maybe I'm not using nitrocontins, and settle down this patient with this maneuvers of Lasix or loop diuretics, ARBs or ACE inhibitors. I prefer use ACE inhibitors because of fast reactions. Then if BP is high, still I'll use calcium channel blockers or I'll use beta blockers to control her heart rate. And since I expect this patient to be of ischemic etiology, obviously I like to add atorvastatin with aspirin. And if it's not, possibly then I'll look for a DCMP or dilated cardiomyopathy. Now, how do you differentiate this ischemic versus dilated cardiomyopathy? Again, go back to history. This lady had a history of delivering a child about 6 weeks back. And she says she's breathlessness is there for last 4 weeks. So if I look at carefully, this is a postpartum cardiomyopathy. So obviously I don't expect a coronary disease. Second is her age. She's 33 years old. So again, don't expect a coronary disease. So I'll be treating this patient on a 4 pillars of heart failure with reduced ejection fraction. Diuretics, mineralocorticoids, ACE inhibitor, or we have a combination of sacubitril or valsartans, then beta blockers, and the most important thing is now dapagliflozin or empagliflozins. Diabetic or no diabetics, we have to treat them with this kind of a drugs. If the tachycardia is still persistent, my beta blockers are there, my BP is low, ivabradine would be drug of choice.
Yes.
And same thing, once you treat this patient, go back and see the IVC next day. Look, go back and see her diastolic function. Look and go back and see her TRZ gradients. Obviously, they'll start reverting to normal. And the most important clinical factors in this subset of population is their weight. And these people, they lose significant amount of weight over a period of time. So you have to check weight every day in the morning. Like once you pass stool or urine, you have to check their weights. And this is how the clinical management happens. And once the patient is fully settled down, I'll still always, I'm not saying that my statement would may be controversial. I may still go for a coronary angiograms. Why I'm saying that? Because age is no more a limitations. The females are more prone than males. And it's easy to treat ischemic heart disease rather than treating a dilated cardiomyopathy with normal coronaries. Correct? Dr. Rupali, go ahead.
IV iron also if patient is having anemia because she's postpartum.
Obviously, if the patient has got anemia, so what you'll do? The answer would lie, look at the ferritin levels. If your ferritin level is less than 20, obviously transfuse them with barium carboxymaltose. Calculate their weight, calculate their dose, and like these people, you have to be very slow in giving fluids. Very slow. Like what I do is, I'll take about 500 milligrams of a barium carboxymaltose, add into 50 ml of a normal saline, give it over a period of 2 to 3 hours. Correct. Any other factor, B12, folic acids, iron deficiencies. Those are secondary parameters which you have to take care of. And this same patient would have come after fever. I would not have thought of a cardiomyopathy. I would have thought toxin myocarditis. I hope I'm able to show you like what I wanted to show you. Let's go back to one or more examples. I hope you're not tired and not hungry anymore. Okay. So let's go for this patient. Avinash, you want to ask something?
Sir, how can diagnose Minoka and its investigations? What are investigations?
Minoka is like coronary disease. All factors of a coronary disease are present. Everything is present, but we do an angiogram is normal. So that's a separate topic. Let's not get into that topic. Right? All right, let's move to one more patient. Now, look at his LV function first. Good, bad, horrible, or normal? Four chamber view. Normal ejection fraction. Two chamber is also normal. Three chamber is also normal. The patient is breathless. So let's look at the parameters of diastology. So we'll start with, this is pulmonic. So I'll go to mitral patterns now. Any one of you can take paper, start writing so that we go to that algorithm again. Now, normal LV systolic function, E wave is 127, A wave is 74, ratio is 1.71. Then we look at E prime septal, that is 6, E prime lateral is 8. Septal 6, lateral 8, and average E to E prime ratio is 18.25. Then third is, we look at LA volume, 33.9 mil, just borderline. So what else we need? TRZ. TRZ is 3.68. What else we need?
Diagnosis.
What?
Sir, nothing in this because 3 positive
Grade
EAS is
2 it should
grade
be.
2, sir. It's grade
Grade
2, sir. Because 3
ये
is
तो देख
positive.
यार, आप तो मेरे से भी स्पीड पे जा रहे हो। हम इसका LS strain कैलकुलेट करना चाहेंगे।
Because both the 3 is positive, sir. So
both the 3 is positive.
Yeah, and it is EA issues less than 2. It is grade 2, sir, automatically. So yeah.
Okay, let's look at it. I'm going to stop this over here and close this presentation so that we're out of this. All right. So I'm going to my own algorithm slide. You can see my slides now. So E prime velocity is less than 6. It is 6. Less than 6 or equal to 6. It is 6. E prime lateral is 8. Is not there. Average is, we have to calculate average. E2 prime average is not 6.5.
7.
So average is 7. So one parameter is positive, 2 parameters are not correct. Then my average E2 prime ratio is more than 14. So one parameter is okay. PR jet velocity, 2 parameters are positive. So 2 parameters are positive, all normal. We have to go to any abnormal 2 variables. So 2 variable abnormal. Now I have to look for LA volume index. LA volume index is less than 34 cc. So more than 1 is to be positive. I have not seen SD wave or LS strain or LVI. Out of these 3, 1 has to be positive. So I say SD wave, LS strain, and this. If 1 is positive, we go to increase LA pressures. If 1 is not positive, we look at IVRT. And if that is there, then we think of raised LA pressure. If it's not, none is present, we go back to either none. If the patient is still symptomatic, we do diastolic exercise test. So we have 2 abnormal parameters. We have to look at LA volume index or we look at LA strains. If 1 is present, we go to increase LA. Suppose my LA volume is more than 34 cc. So I'm going to increase LA pressures. Now look at the ratio. My ratio, E2 prime ratio is 1.71. So it's become less than 2. So it's grade 1 with elevated LA pressures. Grade 2 with elevated LA pressures. But the problem with this patient is, this patient has got a normal LV systolic functions. Once the patient has got a normal LV systolic function, we start looking at something more. We start looking for heart failure with preserved ejection fractions. So we look at these things for diabetic hypertensives, and then we look for elevated LA pressure. We talk of heart failure with preserved ejection fractions. Again, a big topic, not going to this, but at this level, you can say this possible patient belongs to grade 2 diastolic dysfunction with elevated LA pressures. And what does it reflect to management issue? When LV function is normal, patient is dyspneic, we always start looking for reducing their LA pressure by using ARBs or ACE inhibitors, along with diuretics if IVC is bigger in size. So everything comes back to when we start looking at these kind of a thing in clinical perspectives. All right. Any questions before we take our attendance today? We'll try to look for systole and diastole again and again.
Sir, can we write heart failure with preserved ejection fraction on the basis of echo diastolic function only?
Big question you have asked me today, Avinash. Because if I'm suspecting there are two things which are present in heart failure projection fraction, we should have an echo parameters and we should have NT-proBNP levels. Wait a minute.
If I have NT-proBNP report and diastolic detailed diastolic dysfunction with LARS and LAVI and all other parameters, E prime, E by E, A prime, then PR velocity.
The diagnosis of heart failure projection fraction, let me just give me a second. It's a big topic. I'll just take a few minutes to share with you. This is the guidelines published just a week away. Management of heart failure with preserved ejection fractions. It was published on 22nd of July. So what this guideline says, that two important factors for diagnosis of heart failure preserved ejection fraction is, the most important factor is you have a echo parameters or you have NT-proBNP levels which are high. One of these. Look, it's at elevated NT-proBNPs and evidence of cardiogenic pulmonic systemic congestion. And this is the most important thing is we have to have a normal ejection fraction. Second important factor in this subset of population is we have to differentiate whether we are dealing with heart failure preserved or heart failure mimic ejection, like people who are mimicking like heart failure preservation fractions. So we have to exclude valvular, coronary disease, ischemic heart disease, cardiomyopathies, hypertrophic cardiomyopathies to say that they do not belong to heart failure preservation fractions. And next important thing is a clinical syndrome. So you have to have a diagnostic scoring of this heart failure patients. So what is a diagnostic scoring? There are two diagnostic score in this patient in this present is. These patients are presenting with dyspnea and this patient presenting with edema. So cardiac causes of dyspnea, many of them, you have to exclude. Pulmonary, separate. Other sources like anemia, neuromuscular, deconditioning, obesity, anxiety. Same is for edema. And then you go for scoring of these people. So there are two scores. Look, these are non-cardiac mimics. These are diagnostic evaluation for non-high output states. Cardiac mimics. And after this, you have to have two different scores to calculate their probability of heart failure with preserved ejection fractions. Once we have this scoring done, then the biomarkers, the NT-proBNP is useful apart from those biomarkers. Echo markers, not biomarkers, echo markers. I'm just looking where those echo markers is. There's two scoring systems present. And based on them, we call them as heart failure with preserved ejection fractions. I'm just looking at the markers. Give me time. Not seen in this. So it's a full example, like patients whom you suspect for a heart failure preserved ejection fraction, you have to do a complete evaluation in this subset of population. A patient who's got a normal ejection fraction with valvular lesions, obviously we cannot say that it's heart failure. Majority of these people are they're hypertensive or diabetics. And these people, the heart failure could be associated with obesity also. So we have to outline. We can at this point we can say what is my diastology grade 1, a normal, grade 2, or grade 3. Till now we can conclude in that. Like if you talk of a heart failure, that's a separate topic again. If you want to join your management issues, Sunday I'm delivering a talk in Crown Plaza in Rohini. I'll be discussing a couple of points, latest up-to-date guidelines.
Okay. Thank you, sir. Thank you.
So let me start taking your attendance quickly. It's almost 11:35. So Gautam Devnath was present. Dr. Rahul Sangwan.
Present, sir.
Now quickly everybody. Shailendra was present. Nilomani.
Present, sir. Present, sir.
Dr.
Yes, sir.
Nilomani.
Yes, sir, I'm there.
Dr. Abhishek Ganesh Kesarwani. Row number 6.
Present, sir.
7.
Present, sir.
8.
Present, sir.
9.
Present, sir.
10.
Present, sir.
11. 12. 13.
Present, sir.
14.
Present, sir.
15.
Present, sir.
16.
Present, sir.
17.
Present, sir.
18. 19. 20.
Present, sir.
21.
Yes, sir.
22.
Present, sir.
23.
Present, sir.
24.
Present, sir.
25.
Present, sir.
26.
Present, sir.
27.
Present, sir.
28. 29.
Present, sir.
30.
Present, sir.
31.
Present, sir.
32.
28 present, sir.
28 present. Okay. Sachin Bhimrao Jai Bhai.
Yes, sir.
Okay. 32. 33. 34.
Present, sir.
35.
present.
35.
Present, sir.
तो मत भाई थोड़ी देर जग जाओ फिर सो जाना. 36.
Yes, sir.
37.
Present, sir.
38.
Present, sir.
So absentees, you can listen your name. If you are present, let me know. Dr. Abhishek, roll number 5. Then absentees are Vasant Kumar, 11, and 12 is Chenna Reddy. Then Dr. Siddhansh Agarwal.
Sir, roll number 5 present.
कहाँ सो रहे हो भाई? अब क्यों नहीं उठते आप? Dr. Siddhansh Agarwal, roll number 19. Then Aditya Davhale, Ashwin Kumar Davhale, Maharashtra. Sagar MK, Karnataka. So absentees are 1, 2, 3, 4, 5 out of 38 today. Now online alone, roll number 1, Rupali is present, Rachel is present. Roll number 2,
Present, sir.
3, 4.
Present, sir.
Roll number 4, present, sir.
3
All
present.
right, 4 is present. 5, 6,
Present, sir.
7.
Present, sir.
Which one is present?
6 present, sir.
Okay. 7.
Present, sir.
अविनाश तुम्हारे में किसी लेडी की आवाज आ रही है?
पता नहीं.
Surbi Thakur present. Roll number 8.
Present. Present, sir.
9.
Present, sir.
10.
Present, sir.
11. 12.
Present, sir.
13.
Present, sir.
14.
Present, sir.
15.
Present, sir.
16.
Present, sir.
17.
Present, sir.
18.
Prepare a
Present, sir.
transfer summary of Sushma
Please
Dayani
silent your
Mhatre,
mics, please.
72 years old female, known case of diabetes mellitus, hypertension, and ischemic heart disease, presented with history of slurring
Sachin,
of
अपना mic
speech
silent कर लो.
and regurgitation of food, onset of symptoms since around 10 to 12 hours before admission. On
All right,
examination,
absentees are
patient
roll
had
number
power 5 by
5,
5, right flanter was extensor,
roll
blood
number
pressure
11,
was 110 by 70,
roll
heart
number
rate
18.
was 52.
18 present, sir. 18 present.
Hello. Present.
5 present.
Yeah,
Blood
sir.
sugar
18
was
present, sir.
91. ECG suggested of sinus bradycardia. Patient was suspected to have an acute brainstem CVA. CT
बताओ
scan
क्या
was
करूं
done,
इसका मैं.
which was suggestive of no hemorrhage and cerebral atrophy. On clinical suspicion of brainstem stroke, patient was started on tablet aspirin, 150 milligram.
All right.
18 is
So,
present, sir.
pardon?
Roll number 18 is present, sir.
I'm done. Dr. Jitendra
So-
Gedam is present, absent. All right. Previous batch repeat person, Rajan Verma.
Present, sir.
Naresh Kumar Jangade, Rakshpal Singh, Ajay Jairam Chaurasia, Kamal Malviya, Shabir
Present,
Ahmed
sir.
Khan. So 4 are absent out of 6. All right, friends, let's stop over here. I think we'll have a good time. Next week, we'll start with the cardiomyopathies. Okay, take care, stay safe. See you next week with another episodes.
Thank you, sir. Thank you so much.